When one of the nation's largest health insurers announces it is slashing prior authorization requirements for children by nearly 2/3, is it a monumental victory for patient care or a carefully calculated sleight of hand?
Right. It's a massive question.
If you enjoy content like this, please take a moment to like, subscribe, follow, and turn on notifications so you'll always know when new content is released.
Yeah, it really helps us out.
As a quick update, we continue to monitor the Martin Stevens v. OpenAI matter. It is important to note that this is still not a lawsuit. We remain in a voluntary quiet period at the request of Martin Stevens to allow time for any potential developments behind the scenes.
Exactly. We're just waiting to see what happens.
At the time of this recording, we do not know whether any progress has been made. No settlement discussions or negotiations have been publicly confirmed.
Right.
We can also report that the dead man switch has not been activated, meaning Martin Stevens remains safe from both a physical and legal standpoint. We will provide updates if circumstances change.
We definitely will.
Welcome to the debate. Today we are examining a really major policy shift that has immediate, tangible ramifications for the American healthcare system. Specifically, we're focusing on pediatric care.
Yeah, this is a big one.
It really is. UnitedHealthcare has announced a massive rollback of its pediatric prior authorization requirements. By the end of 2026, they plan to eliminate nearly 2/3 of these requirements for members under 18. And this applies to both commercial and Medicaid plans.
Right. The scope it's pretty unprecedented on paper.
Exactly. We are talking about the removal of pre-approvals across, high-friction areas. Diagnostic services, routine surgeries, and specialty care, specifically cardiology, neurology, pulmonology, and orthopedics.
All the heavy hitters.
Yeah, all of them. Alongside this, they are implementing what they call authorization waivers for leading pediatric hospitals. So the central question we are exploring today is this: does UnitedHealthcare's pediatric prior authorization rollback represent a substantive systemic reform that returns medical decision-making to doctors?
And this is where I land. Is it merely a strategic administrative adjustment? One that eliminates unprofitable paperwork while preserving the most restrictive barriers to complex, life-saving care.
Right. Well, I will be arguing that this rollback is a fundamental, structural improvement to the delivery of pediatric medicine. I think it perfectly aligns corporate efficiency with the urgent need to reduce provider burnout.
And I will be arguing that this move is an illusion of reform. I mean, sure, it might reduce the sheer volume of paperwork, but it is a calculated administrative trimming. It leaves the most restrictive, algorithm-driven gatekeeping mechanisms firmly in place for high-stakes, complex care, which is precisely where prior authorization causes the most catastrophic harm.
I see where you're coming from, but let us begin by laying out the foundation for why this shift in healthcare policy is just so profoundly significant. To understand the gravity of UnitedHealthcare's announcement, we first have to understand the daily reality of a pediatric clinic today.
It's a nightmare, administratively speaking.
Complete nightmare. For decades, prior authorization was utilized as a targeted tool. It was theoretically designed to, prevent the overprescription of dangerous narcotics or to ensure that an unproven experimental surgery wasn't billed to the collective risk pool.
Right. It had a very narrow original intent.
Exactly. But over the last 20 years, that mechanism has metastasized. It has become ubiquitous daily friction applied to almost every facet of specialized care. What UnitedHealthcare is doing here is not a minor adjustment to that system. It is a structural paradigm shift.
Well, paradigm shift is a strong phrase.
But I think it's warranted. By removing 2/3 of pediatric prior authorizations and instituting waivers for proven hospitals, they are tangibly reducing an administrative burden that has literally reached a crisis point. We have to look at the scale of this. This pediatric rollback is part of their broader, stated goal to cut overall prior authorization volume by 30% across all ages by 2026.
Sure, the numbers look big.
When an insurer voluntarily dismantles the bureaucratic friction for routine pediatric care, like sleep studies, standard imaging, routine outpatient tests, they are actively realigning their operational model to trust providers. This directly answers the medical community's long-standing demand to reduce the mountain of paperwork.
Okay, but
Just to finish the thought, more importantly, it means that instead of parents spending their afternoons fighting insurance portals and listening to hold music, they can focus entirely on their children's health.
the scale of that 66% reduction certainly sounds impressive when delivered in a corporate press release, I'll give you that. But I urge us to look at exactly what is being cut and, more crucially, the underlying mechanics of why it is being cut.
Okay, let's look at the why.
Well, the American Medical Association's president, Dr. Bruce A. Scott, analyzed this and rightly pointed out that insurers are merely nibbling around the edges. To understand why I view this as an illusion of reform, we have to look at the economics of prior authorization from the insurer's perspective.
You think this is just a financial play?
I absolutely do. Processing a prior authorization is not free for an insurance company. It requires immense infrastructure, intake portals, administrative staff to route the requests, medical directors to review them.
Right, it's a huge operational cost.
Exactly. If UnitedHealthcare is approving the vast majority of routine, inexpensive requests anyway, then paying a staff of nurses and administrators to review and approve them is simply a massive waste of corporate overhead.
I mean, sure, it saves them money, but
Let me finish this point, because when you examine UnitedHealthcare's highly restrictive 2026 clinical guidelines alongside their overarching financial strategies, which, we will discuss later with the Medicaid fraud lawsuits, a very different picture emerges. This rollback merely cuts administrative bloat for routine care. It is a cost-saving measure for the insurer's own balance sheet.
okay, but even if it is a cost-saving measure, how does that negate the benefit?
Because for anything involving deep clinical complexity, the exact scenarios where a delay in care can be life-threatening, the gatekeeping mechanisms remain obstinately in place. You cannot claim to return decision-making to physicians when your own internal guidelines dictate the exact anatomical parameters required for a child to receive follow-up imaging for a congenital heart defect.
I see why you think that, but let me give you a different perspective. Let's focus on that initial 66% reduction for a moment, because we cannot dismiss the sheer volume of this rollback simply by attributing it to corporate cost saving.
I'm not dismissing it, I'm contextualizing it.
But even if we concede that UnitedHealthcare is saving money on administrative overhead, why must that automatically invalidate the benefit to the patient and the provider? We are talking about eliminating requirements from members under 18 across specialties that are notorious for high friction.
That's true. Cardiology and neurology are brutal for prior auths.
Exactly. Cardiology, neurology, pulmonology, orthopedics, these are disciplines where prior authorizations have historically bottlenecked daily workflows to a degree that is frankly difficult for outsiders to comprehend. Let's explore how a routine prior authorization actually functions in practice.
Please do.
If a pediatric neurologist wants to order a standard EEG for a child with suspected absence seizures, under the old system, the clinic's administrative staff must gather all the clinical notes, then they log into a clunky third-party portal, submit the request, and wait.
And usually wait for a denial.
Right. Often, the request is initially denied by an algorithm just because a specific box wasn't checked. This forces the physician to schedule a peer-to-peer review. This means a highly trained pediatric neurologist has to block out 45 minutes of their day to get on the phone with an insurance company's medical director,
Who might be a retired general practitioner with zero specialized neurology training.
exactly, just to explain why the EEG is necessary. By drastically reducing the paperwork for things like this, UHC is directly addressing the very issue the AMA has been screaming about. UHC CEO Tim Noel summarized it perfectly. Parents should be able to spend less time having to navigate the health system and more time focusing on their children.
It's a great PR quote.
But it's also true. If a pediatrician does not have to engage in that 45-minute battle for a basic diagnostic test, that is a monumental victory for the delivery of care. How can you look at a clinic getting thousands of hours of its time back and call it an illusion?
Look, I come at it from a different way. I don't deny that the clinic gets time back on the routine cases, but I fundamentally question what happens to the cases that actually matter. The sheer volume of the reduction is precisely what makes it a sleight of hand.
How is giving doctors their time back a sleight of hand?
Because when you cut 66% of prior authorizations, you are overwhelmingly cutting the cheap, high-volume routine requests.
The 33% that remains, that is the critical fraction. UHC explicitly states in their own announcement that prior approvals will remain in place for complex care and services with high clinical complexity or variability.
Right, which makes sense from a risk management perspective.
But complex care is exactly where prior authorization causes the most catastrophic harm. Dr. Scott from the AMA noted that true reform requires significantly reducing the volume of requirements for life-threatening events. Removing friction for a routine sleep study is fine, but it does not address the core philosophical problem.
Which is what, in your view?
That the insurer believes it is better equipped to determine the necessity of complex care than the treating physician. Let me ask you this. If the time freed up by removing routine authorizations is meant to help doctors, does that extra time actually make the complex authorizations any easier to navigate?
I would argue that it absolutely does. If you remove 66% of the volume, aren't you inherently freeing up the entire clinical apparatus to focus on the 33% that truly requires rigorous clinical scrutiny?
I'm not sure bandwidth is the main issue there.
Think about the cognitive load on a physician, though. If they are constantly inundated with administrative friction for mundane things, they experience extreme decision fatigue and burnout. By clearing out the underbrush, we give that clinic its oxygen back.
Okay, they have more oxygen, but the wall is still there.
But when that complex case does arise, the case that genuinely requires a nuanced, multidisciplinary approach, the physician now has the bandwidth to gather the necessary literature, consult with colleagues, and engage in that peer-to-peer review with full attention. They aren't squeezing it in between arguing over a routine sleep study.
That assumes the insurer is actually going to listen to the literature.
Furthermore, we shouldn't let the perfect be the enemy of the good. You mentioned earlier that the cutting to 66% saves UHC money. That represents a mutual alignment of incentives. The clinic saves time, the insurer saves money, and the child gets the routine test faster. When corporate incentives align with patient access, we should recognize that as a functioning system, not dismiss it as a sleight of hand.
The problem with your clearing the underbrush theory is that it assumes the obstacle in complex care is merely a lack of physician time. It is not. The friction in complex care isn't about the doctor lacking the bandwidth to argue. It's about the insurer utilizing incredibly opaque, rigid criteria to deny care regardless of how flawlessly the physician argues the case.
You think the criteria are that rigid?
Absolutely, the insurer holds all the cards. You could give a pediatric cardiologist 5 uninterrupted hours to prepare for a peer-to-peer review, and it wouldn't matter at all if the insurer's proprietary algorithm dictates that the patient's specific physiological markers don't perfectly align with a predetermined spreadsheet matrix.
But there has to be some standardization.
The barrier isn't time. The barrier is authority. The insurer is maintaining absolute authority over the most expensive, life-altering treatments under the guise of managing clinical variability.
But clinical variability is precisely what needs to be managed. We cannot pretend that every single decision made by every single physician in America is flawlessly aligned with the most current, evidence-based medicine.
I'm not saying they're infallible.
Right. And the data clearly shows that clinical variability is a massive driver of both poor patient outcomes and astronomical healthcare costs, which actually brings us perfectly to the next major component of UnitedHealthcare's announcement. This directly addresses the issue of authority and trust.
You're talking about the waivers.
Exactly. We absolutely must examine who is benefiting from these rollbacks, specifically through the implementation of these authorization waivers. UHC is rolling out waivers for certain procedures at leading comprehensive pediatric hospitals. This is a brilliant, necessary shift toward value-based care. By granting these waivers, UHC is actively rewarding facilities for their consistent use of well-established care practices.
Wait, before you explain the mechanics of it, we need to clarify what value-based care actually means in this context, because it's a buzzword that gets thrown around a lot in health economics.
Certainly. So in a traditional fee-for-service model, a hospital gets paid for every test, every scan, and every procedure they perform, regardless of whether it actually makes the patient better.
Right. The incentive is just volume. Do more, bill more.
Exactly, which incentivizes overutilization. Value-based care attempts to flip that paradigm by rewarding hospitals for positive patient outcomes and efficient use of resources. The authorization waiver program UHC is implementing is essentially a gold carding system.
Gold carding, right.
Let me use an analogy that most people are familiar with: TSA PreCheck at the airport. If you are a known traveler who has undergone a rigorous background check and proven that you are low risk, the TSA allows you to bypass the friction of the standard security line. You don't have to take off your shoes or unpack your laptop. You have proven your compliance, so the system trusts you.
Okay, I see where you're going with this.
UHC's waiver program applies this exact logic to pediatric hospitals. If a comprehensive pediatric center has statistically proven through their historical claims data that their doctors consistently adhere to evidence-based medical guidelines and do not order unnecessary low-value tests, the insurer steps back.
They just give them a free pass?
They grant them a waiver, effectively giving them a TSA PreCheck status for medical procedures. It is the exact opposite of the micromanagement you are concerned about. It is an empirical acknowledgement that certain proven providers have earned the autonomy to make clinical calls without jumping through bureaucratic hoops. Should we not incentivize all hospitals to meet that gold standard of care?
I appreciate the TSA PreCheck analogy, I really do. But let's follow that metaphor to its logical conclusion, to understand why this waiver system threatens to create a deeply inequitable two-tiered healthcare system.
How is rewarding quality inequitable?
Because to get TSA PreCheck, you have to pay a fee, travel to an enrollment center, and navigate a bureaucratic application process. It inherently favors people with the resources, time, and geographical proximity to do so. Now apply that to hospital systems.
But hospitals aren't paying a fee for the waiver.
They are paying an administrative overhead. UnitedHealthcare did not publicly identify which specific facilities actually get this gold card designation. They vaguely claim it covers a broad national network, but the opacity of the selection process is alarming. Consider the immense administrative infrastructure required to prove to an insurer that your hospital consistently uses well-established care practices.
It's just submitting claims data, which they do anyway.
It's way more than that. An elite, well-funded urban pediatric center has entire floors of data analysts, clinical documentation improvement specialists, and compliance officers whose sole job is to track metrics, package data, and prove their excellence to insurance companies. They have the resources to essentially buy their way into the PreCheck line.
I think you are really mischaracterizing the nature of clinical data tracking here. It isn't about buying their way in. It's about utilizing modern health informatics to ensure quality control.
But the ability to utilize those modern health informatics is entirely dependent on capital. What happens to the child who relies on a smaller, rural facility or a non-designated regional hospital that operates on razor-thin margins?
Well, those hospitals cannot afford a team of data scientists to negotiate waiver statuses with UHC. Therefore, they are stuck in the standard security line, facing the exact same old bureaucratic hurdles for complex care. The disparity in care delivery will only widen.
I think that's a bit of a leap. Is it? A child in a wealthy urban center gets rapid, unencumbered medical intervention for a complex neurological condition, while a child in a rural county has their care delayed for weeks because their local hospital doesn't have the administrative leverage to secure a secret gold card status? When healthcare access is predicated on the administrative wealth of the local hospital, the insurer is not trusting physicians. They are simply rewarding corporate consolidation.
That is a highly cynical view of what is essentially a quality control mechanism, though I do understand why the geographical disparity concerns you. However, you are assuming that UnitedHealthcare is blind to the struggles of rural healthcare, which completely contradicts their recent corporate actions.
How so?
UHC is acutely aware of the fragility of rural health infrastructure. Concurrently with these pediatric rollbacks, UHC recently announced they are accelerating payments to roughly 1,500 rural hospitals across the country to improve their cash flow.
Well, cash flow isn't clinical autonomy.
But wait, furthermore, they are broadly exempting rural providers from many prior authorizations altogether, precisely because they recognize that those providers lack the administrative bandwidth you just described. So the narrative that this waiver program is designed to punish under-resourced hospitals just doesn't align with the broader policy shifts they're enacting.
I mean, exempting them just to keep them afloat is different from trusting them.
But they are deploying waivers for elite centers to establish benchmarks of excellence, while simultaneously removing friction for rural providers to keep them viable. If an elite pediatric center develops a clinical pathway that consistently yields better outcomes with lower unnecessary utilization, rewarding them with a waiver creates a standard. It provides a blueprint that other facilities can adopt to achieve that same operational freedom.
Exempting rural providers from some prior authorizations to keep them from going bankrupt is a financial patch. It's not a systemic clinical philosophy. And while accelerating payments is helpful for a hospital's cash flow, it doesn't change the underlying reality of how clinical decisions are being policed.
Policed is a strong word.
It's the accurate word. To truly test this theoretical debate over waivers, rollbacks, and who gets trusted, we cannot just look at the overarching press releases. We have to look at the actual clinical frameworks UHC is putting in place to govern the care that is not waived. I want to dive deep into their newly released document, the Cardiovascular and Radiology Imaging Guidelines V3.0 2026.
I welcome that, actually, because those guidelines are the bedrock of evidence-based medicine.
Let's see if you still feel that way once we look at the granularity. These guidelines govern what happens when a physician needs to order advanced imaging or cardiac interventions. If UHC is truly stepping back, as you suggest, and trusting physicians to practice medicine, why are their own internal guidelines so intensely micromanaged?
They are standardized, not micromanaged.
Let's look at specific, undeniable examples directly from their source material. Take pediatric implantable cardioverter defibrillator insertions, referred to in the billing world under specific CPT codes and in their document as CRID-12.
Okay, CRID-12.
For the listeners, an implantable cardioverter defibrillator, or ICD, is a device placed in the chest to monitor heart rhythm and deliver a shock if it detects a dangerous arrhythmia. The UHC guidelines require highly specific, rigid criteria for a child to be approved for this device.
As they should, it's a major surgery.
But listen to the criteria. For instance, in cases of long QT syndrome, a genetic heart rhythm disorder that can cause fast, chaotic heartbeats, the guidelines dictate that the child must either be a survivor of sudden cardiac arrest or have active symptoms that are failing beta blockade therapy.
Right.
Furthermore, the guidelines state that cardiac sympathetic denervation, a surgical procedure to remove nerves that stimulate the heart, must be ruled out as an effective alternative.
Wait. Before you frame that as an overreach, let me ask a clinical question. Are those not entirely appropriate clinical guardrails established by cardiological societies? Why shouldn't an insurer ensure that less invasive or alternative therapies like beta blockers have been adequately trialed before surgically implanting a defibrillator into a child's chest?
Because medicine is not a flowchart. What if the pediatric electrophysiologist determines that while the child hasn't technically failed beta blockade yet, their specific genetic mutation of long QT syndrome puts them at an imminent catastrophic risk of sudden cardiac death?
Well, then they would appeal.
But waiting for the beta blockers to fail could literally mean waiting for the child to die. Under these guidelines, the physician's preemptive clinical judgment is completely nullified by a prerequisite checklist. But it gets even more granular and restrictive. Let's look at the surveillance monitoring requirements after a Fontan procedure.
Okay, the Fontan procedure is incredibly complex.
Very much so. For context, the Fontan procedure is a highly complex, multi-stage open-heart surgery for children born with a severe congenital defect where they only have one functioning ventricle. The surgery fundamentally reroutes the venous blood return directly to the pulmonary arteries, bypassing the heart's right side entirely.
Right. And because of that unique circulatory pathway, these patients require lifelong, highly specialized monitoring, particularly because the altered blood flow causes chronic venous congestion, which can severely damage the liver over time.
Exactly. And because of that massive risk, UHC's 2026 guidelines dictate exact surveillance intervals for these children. They mandate an abdominal ultrasound every 6 months and a specific advanced imaging technique called MR elastography, which measures the stiffness of the liver to detect fibrosis every 6 months.
That sounds like a very thorough standard of care.
The document even specifies the exact CPT codes, which are the billing codes physicians must use to ensure absolute compliance. Now think about the biological reality of a child recovering from a Fontan procedure. Human biology does not adhere perfectly to a 6-month spreadsheet matrix.
No, but
If a pediatric cardiologist sees a subtle,
cascading physiological shift at month 4, perhaps a slight change in fluid retention or liver enzymes, and wants to order that MR elastography to check for rapid fibrosis, they are technically outside the UHC guidelines. If the physician orders it, the algorithm checking the CPT codes in the patient's timeline will trigger a denial because it doesn't fit the predetermined grid.
But the guidelines are not designed to punish the physician. They are designed to establish a standardized baseline of care.
Let me give you another example before you defend the matrix. Look at the requirements for suspected superior mesenteric artery syndrome, or SMA syndrome. This is a rare, potentially life-threatening gastrointestinal condition where the first part of the small intestine is compressed by 2 arteries, usually due to rapid, severe weight loss.
Right, SMA syndrome.
The guidelines dictate that advanced imaging can only be approved based on the documented presence of severe debilitating illness or significant weight loss leading to retroperitoneal fat loss, or consider evaluating pectus excavatum, a condition where a child's breastbone is sunken into their chest.
Okay.
The guidelines explicitly dictate that a physician must order a CT scan without contrast or an MRI with 3D reconstruction, but only if the patient is already deemed a candidate for surgical correction and has identified cardiac or pulmonary dysfunction. Every single one of these examples proves that for anything beyond the mundane, routine sleep study, the insurer is still fiercely practicing medicine via spreadsheet.
I wouldn't call it practicing medicine.
They are dictating the exact modalities of the scans, the exact intervals in months, and the exact physiological prerequisites required to unlock the care. That is not stepping back. That is asserting dominance over the clinical encounter.
I hear the frustration in your argument, and I genuinely understand why a physician would bristle at having their decisions checked against a matrix. Nobody likes feeling micromanaged. However, I have to defend those guidelines using the very principles of evidence-based medicine that protect patients.
Protect patients from their own doctors?
Sometimes, yes. You are characterizing clinical precision and standardization as bureaucratic micromanagement, but these guidelines are fundamentally rooted in patient safety. We have to look at the macro-level data regarding pediatric imaging. The guidelines specifically note the rampant overutilization of advanced imaging in pediatrics.
Overutilization is an insurance term for we're paying for too many scans.
It's also a medical term for exposing children to ionizing radiation unnecessarily. The UHC guidelines specifically push providers toward less ionizing options, explicitly recommending ultra-low-dose CT scans or MRI over standard CT scans whenever possible. Why? Because unnecessary radiation exposure in childhood exponentially increases the lifetime risk of developing malignancies.
Yes, radiation is a risk, but
these rules aren't arbitrary corporate barriers designed to save a few dollars. They are vital safeguards against low-value, potentially harmful care.
I actually want to understand your perspective on this, because it seems like you are granting the insurer the moral high ground on patient safety here. Are you arguing that without UHC's strict intervals, pediatric cardiologists would just carelessly radiate children?
No, I am not saying pediatricians are careless, but human beings, including highly trained experts, are fallible, and they are subject to massive systemic pressures. Defensive medicine is a huge problem in the United States. A physician might order a high-radiation CT scan simply to protect themselves from potential liability, even if an ultrasound would suffice.
So UHC is saving them from themselves?
The UHC guidelines exist to disrupt that pattern. When UHC requires specific 6-month intervals for Fontan procedure surveillance, they are not pulling that number out of thin air. They are aligning their authorization algorithms with established societal guidelines from pediatric cardiology boards to ensure longitudinal, consistent tracking of liver complications. The consistency is what allows for accurate tracking of disease progression.
But again, the strict timeline. Furthermore, we have to recognize that UHC does not operate in a vacuum. The guidelines explicitly reference the Centers for Medicare and Medicaid Services, or CMS, policy hierarchy. This hierarchy clearly states that state Medicaid policies or independent third-party criteria like EVCOR, which is a major medical benefits management company, apply systematically to ensure that care is objectively reasonable and necessary.
EVCOR criteria are notoriously rigid, too.
But the specificity of these guidelines protects the child from an overzealous or overly cautious provider ordering high radiation scans without a verified clinical indication. The structure is there to catch the 80% of cases that fit the standard evidence-based pathway, allowing the healthcare system to run safely and efficiently. I'm sorry, but I just don't buy that the primary motivation here is shielding children from ionizing radiation. Let me tell you why. The insurer is adopting the noble language of patient safety to justify an architecture of absolute financial control.
That's a pretty heavy accusation.
It's the reality. You mentioned that the matrix is designed for the 80% of cases that fit the standard pathway. But what happens to the 20%? If the guidelines dictate the exact months for surveillance imaging of an atrial septal defect closure, a common procedure to close a hole in the heart, based on physiological stage A, B, C, or D, literally charting out mandatory intervals of 36 months, 24 months, or 12 months, where is the room for the physician's clinical judgment when a child falls into that 20%?
Well, they submit clinical notes for review.
But a child categorized in physiological stage B might exhibit subtle, cascading symptoms that warrant an echocardiogram at 18 months instead of the mandated 24. If the physician orders it, it triggers an automatic denial. The physician must then initiate an appeals process, delaying the care, creating anxiety for the parents, and burning valuable clinical hours.
But they can still get it approved.
Isn't this exactly what Dr. Scott meant when he said health plans need to leave the medical decision-making up to physicians? If the guidelines are truly just helpful guardrails, they wouldn't function as hard stops that deny care the moment a biological reality deviates from the CMS or EV-Core criteria.
But the guidelines explicitly allow for peer-to-peer reviews if a case falls outside the standard matrix. It is not a permanent denial. It is a pause to verify necessity.
A pause that delays care.
That control is necessary precisely because clinical variability often results in worse care. You are idealizing the physician's clinical judgment, treating it as infallible. But the empirical data clearly shows that without guardrails, there is massive overutilization of advanced imaging. The rollback of the 66% of routine prior authorizations clears the path so that when a complex case like your 18-month atrial septal defect example arises, the physician has the time and resources to quickly conduct that peer-to-peer review and explain the deviation. The system is designed to trust the routine and verify the complex.
That brings us to the core issue of trust, and we cannot properly evaluate this policy shift without moving from clinical guidelines to the overarching corporate strategy. You cannot separate these medical policy shifts from corporate motives, profitability, and public relations.
I don't think we need to.
Well, you mentioned trusting the insurer's motives regarding patient safety and the necessity of verification. Just recently, Massachusetts Attorney General Andrea Joy Campbell filed a major multi-million-dollar lawsuit against UnitedHealthcare.
I am familiar with the case, but we need to be very precise about what that lawsuit entails before we conflate it with pediatric prior authorizations.
I agree. Let's be precise. The lawsuit centers around a practice known as risk adjustment coding, specifically within UHC's Senior Care Options program, which serves low-income elderly patients.
Right, so we are talking about Medicare, not pediatrics.
Bear with me. In the Medicare system, the government pays insurers a base rate per patient. However, if the patient is sicker and has more complex diagnoses, the government adjusts that rate higher, paying the insurer more money to cover the anticipated costs of care. The Massachusetts Attorney General alleges that UHC systematically manipulated health assessments and pressured physicians to inflate diagnoses.
Allegedly.
Right, allegedly. Essentially, combing through medical charts to find codes for conditions like severe malnutrition or major depression that the patients didn't actively have to artificially inflate the patient's risk scores. By doing this, UHC allegedly secured over $100 million in excess Medicaid payments.
Again, this is a specific allegation about Medicare billing.
The intense internal pressure to boost these reimbursements reportedly led to the resignation of a top executive. Now, why does this matter for pediatric prior authorizations? It establishes a documented corporate culture of utilizing complex medical coding to extract maximum revenue and protect the bottom line, regardless of clinical reality.
But how does a lawsuit about Medicare risk adjustment coding connect to the decision to eliminate 66% of pediatric prior authorizations?
It's completely disconnected.
It provides the lens through which we must view their motives. Look at the data UEHC released alongside this pediatric rollback. They claim that prior authorization is currently only required for 2% of total medical services, and that 90% of submitted requests are approved within 24 hours.
Which shows they're efficient.
No, if 90% are approved almost immediately, then the prior authorization system is clearly not functioning as a rigorous clinical filter catching bad medicine. It has become a rubber stamp that generates massive internal administrative costs for UHC. So when viewed against the backdrop of the Massachusetts fraud lawsuit, this pediatric rollback looks exactly like a calculated public relations maneuver.
A PR maneuver that helps kids.
The company is facing intense legislative scrutiny, lawsuits from state attorneys general, and immense public backlash regarding patient access. By rolling back the 66% of prior authorizations that are essentially unprofitable administrative bloat anyway, UHC gets to issue press releases claiming they are liberating doctors and putting patients first. It repairs a damaged public image while conveniently reducing their own internal overhead costs. It is a strategic corporate maneuver disguised as a genuine moral shift in clinical philosophy.
I'm not convinced by that line of reasoning because you are conflating two entirely separate operational divisions, vastly different patient populations, and completely distinct strategic goals.
They are the same company.
The Massachusetts Senior Care Options lawsuit, which it is crucial to note UHC has characterized as completely meritless and intends to fight, deals with the intricacies of Medicare and Medicaid risk adjustment coding for elderly populations. It has absolutely nothing to do with the clinical necessity frameworks applied to pediatric, commercial, and Medicaid prior authorizations.
It's all about how they use billing codes to drive revenue.
You are using a localized legal dispute regarding financial coding to invalidate a massive nationwide policy reform that directly affects how children receive medical care. We have to evaluate the policy on its actual merits and outcomes. Let's look at the broader corporate actions that accompany this rollback. As I mentioned earlier, UHC is accelerating payments to 1,500 rural hospitals. They are broadly exempting rural providers from prior authorizations. Furthermore, they are overhauling pharmacy benefit reauthorizations at Optum Rx, which is another massive pain point for providers. Taken together, this shows a systemic, company-wide pivot toward provider collaboration and reducing friction.
Or, a systemic, company-wide pivot to reduce human administrative costs across all divisions.
Even if that is true, we have to ask, does the motive invalidate the positive outcome? Is it good for UHC's bottom line if their internal administrative costs go down? Yes, absolutely. But since when is aligning corporate financial efficiency with patient access a bad thing?
When the complex cases are left out in the cold.
In a market-based healthcare system, that alignment is exactly how progress is made. Even if this entire initiative was born in a boardroom purely to lower administrative overhead and boost public relations, the undeniable empirical results on the ground is a net positive for children and families. A child gets a sleep study scheduled faster. A pediatrician leaves the clinic at 5 p.m. instead of 7 p.m. because they don't have to spend 2 hours on hold. The burden is lifted. We cannot let a cynical view of corporate motives blind us to a policy that fundamentally improves the daily delivery of pediatric medicine.
That is a compelling argument regarding the alignment of incentives. I'll give you that. And I agree that a pediatrician leaving work on time is a universal good. But have you considered the technological endgame of this efficiency?
You mean AI?
Yes. You argue that the rollback frees up physicians, but we must look at how the remaining 33% of complex authorizations will be handled in the future. UHC has pledged to process 80% of all electronic prior authorizations in real time by the year 2027.
Which will speed things up even more.
How does a company process a complex medical request for a Fontan procedure surveillance scan in real time? They don't use human medical directors. They use algorithmic processing and artificial intelligence. What UHC is really doing is standardizing the intake process so an AI model can read the CPT codes,
analyze the patient's age and history, and instantly issue an approval or a denial based on those rigid 2026 clinical guidelines we just discussed.
And if the AI issues an instant approval, isn't that a massive improvement over waiting 3 weeks for a human to review it?
Yes, if it approves it. But what if the algorithm is trained on the exact matrix that requires Fontan surveillance only at strict 6-month intervals? If a doctor orders the scan at month 4 because of subtle physiological changes, the AI doesn't understand clinical nuance. It only understands that the data point deviates from the matrix.
Right, and then it goes to a human for peer-to-peer.
But the initial result is an automated instant rejection. Are we truly improving the healthcare system if we are just trading a slow, human no for a fast, automated no on the 33% of complex pediatric cases that actually matter? The speed of the decision is irrelevant if the underlying clinical judgment of the physician is still being usurped, this time by an opaque machine learning model rather than a medical director. The reduction of human administrative bloat is just paving the way for algorithmic gatekeeping.
Let's synthesize where we stand on this complex issue, as we have covered everything from clinical guidelines to the future of AI in medicine. I maintain that removing 2/3 of pediatric prior authorizations is an undeniable empirical step forward for the American healthcare system.
And we disagree on the true impact of that step.
Right. When you strip away 66% of the bureaucratic friction for children across critical specialties like cardiology, neurology, pulmonology, and orthopedics, you are tangibly reducing provider burnout and expediting essential care for millions of families. By establishing waivers for proven high-quality hospitals, UHC is laying the necessary groundwork for a value-based system that rewards evidence-based practices rather than punishing all providers with uniform paperwork. It is a structural shift that utilizes standardization to benefit the patient, protect against the overutilization of harmful radiation, and improve the overall efficiency of healthcare delivery.
And I maintain that until the opaque criteria governing high-stakes complex pediatric care are dismantled, the core issue of physician autonomy remains unresolved. As evidenced by the exhaustive and deeply restrictive 2026 cardiovascular and radiology imaging guidelines, the insurer is still utilizing strict matrix-driven intervals to override the physician at the exact moments when clinical nuance and individualized care are most critical.
The 33% that's left.
Exactly. Whether this policy shift is driven by a desire to clear the way for algorithmic automation or a need to shed administrative overhead and repair public relations following damaging fraud lawsuits, this rollback leaves the most dangerous barriers to complex pediatric care completely intact.
Well, despite our different interpretations of the underlying motives and mechanisms, we do have significant areas of convergence here. We both firmly agree that the current administrative burden placed on pediatricians and clinical staff is an absolute crisis that requires immediate systemic dismantling.
No question about that.
And we both agree that the true test of this UnitedHealthcare rollback will not be found in corporate press releases, but rather in the exam room, specifically in how it affects the sickest children requiring the most complex, specialized care.
Exactly. This debate highlights the immense value of looking beyond the top-line corporate announcements. To understand the true reality of healthcare economics and patient access, we have to examine the highly granular clinical guidelines, the billing codes, and the technological infrastructure driving these decisions. There is clearly much more to explore regarding how the implementation of AI and real-time electronic prior authorizations will shape the future of medical approvals.
Will the new system simply be a faster, algorithmic way to say no? Or will it truly liberate the physician to practice medicine as they see fit? It brings us right back to our opening thought. Is this the dawn of a streamlined patient-first healthcare system, or just an administrative sleight of hand hiding behind a digital curtain?
The answer, as always, is buried deep in the paperwork.
If you found this episode valuable, please like, subscribe, share, follow, and turn on notifications. It helps us continue bringing you content like this and ensures you never miss future releases.